Hi everyone, welcome to my presentation on the oropharyngeal airway and the correct technique for its insertion. This procedure plays a vital role in maintaining an open airway in unconscious patients. My name is Dr. Lutfi Ismail. I'm an emergency physician from the Faculty of Medicine and Health Sciences, University Malaysia Sabah. And without further ado, let's get started. Loss of consciousness may result in upper airway obstruction, as the relaxation of the jaw muscles can cause the tongue to obstruct the airway. An OPA or Goodall airway is an airway adjunct designed to maintain the airway patency and prevent obstruction caused by the tongue collapsing against the posterior pharyngeal wall in unconscious patient. OPA is used in patients with a loss of airway reflexes, such as gag reflex or cuff reflex. It helps to maintain airway patency by preventing the tongue from obstructing the pharynx. It also facilitates more effective ventilation by keeping the airway open during manual ventilation. OPA reduces airway resistance and improves air entry. Using an oropharyngeal airway on a conscious patient with an intact gag reflex is contraindicated. This could stimulate the gag reflex and lead to aspiration of gastric contents. Here are the oropharyngeal airway. It is available in multiple sizes, each color-coded to assist clinicians in quickly selecting the appropriate size for the patients. Typically, size 000 to 3 are for the children, while size 4 to 6 are used for the adult. Now let's have a look at the anatomy of the OPA. On top of the OPA is the flange, which is going to sit at the entrance of the mouth, where its function is to prevent over-insertion of the OPA. The patient's teeth will be rested on both sides of the reinforced plastic of the bite section or the bite block. The curved body is designed to conform over the tongue as well as the palate. And lastly, the tubular air channel with tapered edges is created to reduce oropharyngeal mucosa trauma during OPA insertion. An oropharyngeal airway prevents airway obstruction by keeping the tongue from falling back and blocking the pharynx. In unconscious or semi-conscious patients, the tongue and the tissue may relax and collapse against the posterior pharyngeal wall, thus obstructing their airflow. There are several mechanisms on how the OPA is able to maintain airway patency. As you can see, the OPA fits over the tongue, pushing it forward and away from the posterior pharyngeal wall. It also maintains airway patency by holding the tongue in place where it keeps the airway open, allowing unobstructed airflow to the lungs. It also prevents soft tissue like the soft palate from collapsing into the airway. An OPA that is too small for a patient may not prevent airway obstruction, while one that is too large may cause trauma to the patient's upper airway. To select correct size, measure from the corner of the patient's mouth to the earlobe. Second method is to align the flange in between the patient's incisor to the angle of the mandible. Now, let's insert the OPA. First, let's position the patient supine and open their airway using the head tilt chin lift maneuver. Hold the OPA upside down with the curve facing upward. Insert it into the mouth along the roof. Once it reaches the soft palate, rotate it 180 degrees and gently advance it until it rests securely. Remember the key points? Insert with the curve facing up, rotate 180 degrees halfway through, and do not force the airway into place. Thereafter, you can apply patient on oxygen supplementation such as high flow mask or ventilate the patient using back valve mask. That concludes my presentation and demonstration of OPA insertion. Thanks for watching and stay safe.